Good afternoon and welcome to Optimizing Ambient AI Adoption Across the Care Team, a health systems CIO production sponsored by Heidi Health. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the founder and editor-in-chief of Health Systems CIO, and I'll be your moderator today. We're looking forward to your questions, your participation. You can send in those questions or comments at any time in the Q&A box, and we'll take them later in the program. Just so you see how we're going to spend our time today, first we're going to go about 35 to 40 minutes with our main panel discussion featuring Dr. Zafar Chaudry, SVP, Chief Digital Officer and Chief AI and Information Officer at Seattle Children's, Dr. Nancy Sabati, Associate CMIO with Beth Israel Lahey Health, and Dr. Thomas Kelly, co-founder and CEO with Heidi Health. And then we will have our Q&A. So let's jump right in. Dr. Chaudry, we're going to start with you. Can you give us an overview of your organization and your role?
Hello, and thanks for having me on the episode. Seattle Children's Pediatric Health System. We're based out of Seattle, but we serve the Pacific Northwest, Washington, Alaska, Montana, and Idaho. 47 sites, about 13,000 people, and about 500 in IT.
All right, very good. Thank you. Dr. Sabati?
Hi, my name is Nancy Sabati. I'm a primary care physician. I'm also the Associate Chief Medical Information Officer of BILH, or Beth Israel Lahey Health. If you haven't heard of BILH before, we are the other big medical health system in Boston, the other which we will not name. But we encompass 13 hospitals. We care for about 1 million patients. We span from southern New Hampshire down to Cape Cod. And in primary care alone, we have over 100 practices.
Excellent. Very good. Dr. Kelly?
Yeah, hi everyone. Thanks for having me on. So yeah, I'm Tom. I'm an Australian doctor by background. So I was a vascular surgery resident, was my last clinical stop. But similar to all the clinicians here, saw a lot of different problems in the admin and the burden that comes with practicing as a clinician. So saw the amazing things that AI could do and started Heidi in 2021 to try to relieve some of that burden for clinicians practicing. And yeah, we now an ambient AI vendor that I think probably the most used in the world. We have large hospital systems from the UK to Beth Israel with Nancy in the US and in Australia and around the world. And yeah, we excited to share more about the experience we've had today.
All right. Very good. Now we're going to switch to first names, be a little less formal, right?
Yeah.
So we'll have a nice fun time here. Okay. Zafar, what problems did you task Ambient AI to solve first and why those? And I'm going to combine that with our next question, which is which specialties or roles adopted fastest and why? So sort of your starting point with these tools.
So we're sort of, I would say, earlier in this phase. The problem we tried to look at is what's happening with our physicians and the challenges they're facing in terms of increasing workload, burnout, which is definitely real, and how physicians want to interact with patients. Because obviously, physicians want to talk to patients, see the patients, not spend all their time typing on a device or trying to look things up. So for us, looking at the ambient AI technology, the use case was how do we make that patient encounter a better experience for everyone whilst taking the administrative burden, somewhat of it, away from the clinician who's trying to see as many patients as they can in a very difficult climate with pressures on access, which is a problem we have in our health system. So we started this journey with a pilot of 50 physicians across different specialties. And we asked for volunteers. There wasn't actually a shortage of volunteers, truth be told. We actually just completed that pilot just a few weeks ago, and we've gone 100% to a full enterprise licensing for physicians and nurses. That's about to start rollout. It's an interesting journey though, because when you look at the different genres of physician we've had, obviously the younger cohort quickly adopts the technology, sees the value of it. Some of the older cohort, somewhat apprehensive of whether it will actually be accurate, how good will it be, will it listen and produce the correct notes into the medical record? And we use Epic as our medical record. But what we've seen over that 90-day journey is a massive, massive increase in utilization. And now everybody's like, why didn't you give it to me? So the good news is they're going to get it if they want it. But when you get comments like, you cannot pry this technology from my dead hands, that that tells you that you know that you are making an impact. And the impact is truly in people having time back. I don't think you actually create more time, but it avoids people working nights and weekends to complete their documentation because it has to be complete. And then you need the documentation to do the coding, to do the billing. So that entire life cycle improves. So we did it as a pilot. Now, this was 100% driven by my informatics team that works in my IT group. My CMIO and partners led this. It wasn't really, I was just the one writing the check for the technology, not the person trying to drive why we should do it. And that, I think, has been really useful in terms of getting the adoption, because it's not that scenario of IT is doing this to us. It's very much, try this out. If it works for you, we will continue to invest in it. And our business case is not built on saving money. It was purely built on, how do we make people's lives easier? Because if you do make people's lives easier, things will happen faster, like billing and everything else, and therefore revenue will improve.
Excellent. Lots of follow-ups there, but I'm going to go around the horn. Nancy, your thoughts?
Sure. I mean, it was a similar journey for us. So really, we were trying to solve the documentation burden that we were hearing across our system. As a PCP myself, I was, one feeling that burden. And so that was our original plan, is really to solve that. So we ran our pilot in 2 phases. We had an initial phase that we called the alpha phase, which was 100 clinicians across all our hospitals and our ambulatory sites. And we were really looking for people who, raised their hand and had some ability to, sort of define themselves as being tech savvy. And so we ran that initial pilot for about 6 weeks, and we asked those folks to actually create the templates for their specialty department. So, and Tom may go into this in more detail, but Heidi gives you the ability to create templates that either works for your specialty or works for you. And so in that way, it's a very flexible tool. After about 6 weeks, we've expanded, and we now have 1,400 clinicians across our system who are using it. And similar kind of feedback, this is a game changer. I love being able to get home for dinner. This has, really changed, how I approach patients. But it's, beyond the documentation time, there were other benefits that maybe we didn't predict as much. And what we hear from our clinicians is it reduces the cognitive load of the visit. So it may not save them time per se, but they don't have to take down every little detail so that they can create their note, because the ambient scribe, Heidi, is capturing that. So we hear that a lot. We hear it's just a better visit. I can put my laptop to the side and have a face-to-face conversation with my patient and not be distracted by the computer. And that was really what we heard as we started to expand it. It's it's documentation time, but it's better than that. It's it's a better visit. It's a better note. It's just creates just a better experience for both the patient and the clinician.
Very good. Tom, your thoughts on what you're hearing?
Yeah, obviously good to hear, and yeah, it's why I hung up the stethoscope. It is pretty amazing stuff. Yeah, I think as far as specialties, I always think of the specialties who have the most general, unstructured presentations are the ones that often get the most benefit most quickly because you can't really get around you can't do any tricks. You can't use short macros or you can't use hotkeys to try to say, this is day 2 post a total knee replacement or something like that. Because if you're a PCP or you're an ED, you could be seeing anything. So I think generally we see that I'd say emergency, ambulatory care specialties, and primary care is where it most often picks up first. Uh, and I think that's also partly to do with the tools, because I think for surgeons and for pathologists and whoever else, what's useful for them may look a little different. It might be that it's their operative notes or an explainer for their patients, or maybe it's chatting with AI to generate something specific that they need. So yeah, I think what Nancy mentioned, I think, is the way to do it. You just need each of the specialties represented, find what the right where the utility is for them, and then create the right content templates that map to the specialty. And you can pretty much convince everyone to use it, and they'll just use it in slightly different ways, I think. Yeah.
Tom, I'm going to start with you. I want to go around the horn on an issue that's been touched on already. This idea of ROI, and you sort of have two. I've heard comments on both sides of this issue. One would be that CFOs need a hard ROI in general. It's very hard to talk to CFOs unless you're really talking concrete numbers and things like that. But you hear a lot of talk when we discuss ambient AI about many types of ROI that are not as hard, but some of it is when we talk about, Dr. Chaudry mentioned the compliance, the documentation, how that flows straight into billing, giving time back, reducing burnout, physician replacement costs, all these kind of things. I just want to go around the horn and have everyone touch on this concept of ROI, the different types of ROI we can see with this documentation. And then I guess CFOs can be of all different varieties, and some are going to be more hardcore and want harder numbers, and some are going to be more open to these nuanced ROI issues of ROI. But Tom, your thoughts?
Yeah, I think I imagine we'll talk about the similar things. So I might to focus on one specific area. So I think definitely there's a lot of value with billing and coding. I think it's just accurately capturing what was actually done ultimately. You know, uh, again, being a surgical resident, I always think of the surgical complications. So, your day 2 post surgery, there's a wound that's bled through because they're on anticoagulation, and you say something like, "Oh, that dressing looks quite nasty. Let's get that changed. Can you check the anticoagulation?" But the poor surgical resident writing a note doesn't create a separate issue for day 2 complicated by excess bleeding, for example. But that would incur a different ICD-10 code and might be a different billable event that should be documented as 2 separate issues, which may cause an unexpected increase in length of stay and all the rest of it. And so I think the just accurately documenting what is actually being done is really, really, really valuable. And then actually, I think the productivity of clinicians was the one that surprised me the most. So I thought it was a vitamin, and that most clinicians would mainly get the quality of life benefit. It might be a bit hard to track. But actually, in the numbers, we see that in emergency, for example, most consultant clinicians will average seeing 1 extra patient a shift if they're using Heidi. And that's like across many different centers, like in the NHS, in the US as well. So actually, I think in retrospect, I think doctors are the type that work really hard. They are trying to be productive. They hold themselves to account on how many patients they can see in a shift, for example. And it's never the thing the doctors get excited about. Oh, if you use this, you can see more patients. But actually, it is what ends up happening. So they feel more relaxed at work. There's less cognitive burden. You can just get through more. So you just end up getting through more. So yeah, I think the 2 main things that I see, like definitely people expect hard ROI. That's why we do alphas, like proof of value. But I think it's, yeah, like it is in the numbers generally if you're using a good tool.
Nancy?
Yeah, so we went into this very specifically saying we were not going to tie this to anything financial. And I know that sounds kind of odd. And I have been part of other AI scribe projects where the message to the clinicians, will give you this tool, but you need to add a session a week, a session, not a session, a patient a week or a patient a day. And that never goes over well. But as we roll this out, we are seeing that is happening in different pockets. So it's not happening, across the board, but we are seeing. So, for example, our earliest adopters were our urologists, and our urologist was mostly driven by a physician champion who really had tried many different types of AI scribes and sort of said this is the one we should try. And so we're seeing in urology added visits, not so much in primary care. The other thing to think about is there is an ROI to retaining clinicians.
Right.
So we have people who leave primary care because of burnout. And so you reduce the burnout. And I have seen this. People said, well, I would have retired early, but because of this tool, I'm going to stay longer. Or we also use it as a recruiting tool. So we have other health systems who are very competitive with us for the best doctors in Boston. And, we have to be able to offer tools that they offer. So there are ROIs that may not translate necessarily in dollars, but they do in the long run. If you lose somebody to an early retirement or to another system, that is a very significant, loss to your system. So I would say the ROI for us is multifold in terms of how we're seeing it used across our system.
And Zafar, these arguments, they work with the CFO type people, or are there going to be some that say, that's not good enough?
I don't think these arguments will work with every type of CFO because there's many types out there. I think we have to change the narrative, though. I'm a true believer that cutting our way to success isn't going to be success in healthcare. And we've found ourselves constantly arguing the save money, cut this, cut that, build ROI for everything. And I would argue that tools like Ambient AI are part of the cost of doing business in healthcare for the future. Anybody, the running joke is you have a conversation with anyone and you have to say AI at least 5 times to be taken seriously. But the reality is AI tools are embedded everywhere already in our daily lives, in our clinical work, in our non-clinical work. So to constantly say, hey, you can only have a tool because somehow it's got to pay us back. It's like saying, why would we have an EMR? But we need an EMR to take care of patients, right? So these technologies, getting the documentation right, goes to patient safety as well, right? Because when somebody's reading that documentation, when you're referring patients between one specialty and another specialty, that's what people look at. Is it accurate? Is it telling us the picture on how to take care of the patient, how to continue that patient's care? So I think the pushback has to be that not everything in healthcare has to be about, well, we need to save the money. And the other thing is most of these are also invest to save schemes. So when you make an investment in this technology, you can't expect to see the benefit that you put it on the Friday and everybody wants the benefit on Monday. You've got to give it time because the thing we don't talk about as much is change management. So this is a change program. We've got to get people on board. We've got to teach them and train them, the ones that need it. Then when they start using it, you will start seeing the benefit to the health system and the patient experience and the clinician experience and the nursing experience. But that might take 2, 3, 4 years. Not, I put it on Friday and by Monday I have to lay off 5 FTEs to cover the cost, or as Nancy said, can we see 4 more patients this week so we can bill more? And I think that's not the right approach. And remember, we're dealing with super smart people. I think sometimes we forget in health systems that all of our clinicians have spent like eons trying to get their training to do what they think is right, which is take care of the patient. And yet we in technology want to tell them, no, you should do it for this reason or that reason. So CFOs, and there's different types, they've got to try and understand that these programs are longer term investments in the success of the health system. And any other AI outside of this ambient space, and we are doing all kinds of different AI tools, you won't immediately see the benefit, right? And it's like even when people are using AI in their office suite to be able to answer emails faster, the reality is you can't get rid of people. It's doing emails actually an additional job to the full-time job that you actually were paid to do. So if you can give people tools that help them get through that faster, you just have happier staff. And I think Nancy's 100% right. How much does it cost to recruit a physician? How much does it cost to lose a physician? And there's competition, right? We're in pediatrics. Our pediatricians don't have to work here. The Children's Hospital in Boston, people would like to work there, right? If they get enticed to come there. It's #1 hospital. So these are things that we have to think about when we're looking at, I like to tell people, look at the holistic picture of the technology you're implementing. Just don't look at a number, because the number's always going to be eye-watering, right? Anthony, is there anything in IT that that is a bargain? And we certainly don't get a BOGO in healthcare technology, right? It's very much you make the investment, you systematically roll it out, you manage the change management. And yeah, over years, you can write up and say, well, what was the value? The other interesting thing to look at with ambient AI is, what does the patient experience now look like? Are patients more satisfied because they get to see the physician who's looking at them eye to eye? Not that they're looking at the physician's back whilst the physician is typing because the PC happens to be mounted on the wall. The only way they can type into it is by turning their back on the patient, right? The patient experience is going to be better. And certainly in pediatrics, it's an interesting patient experience because you're not only talking to the patient, you've got the parents, the caregiver, potentially grandparents in the same room, all of which are asking questions because they're worried about the child. And now you're turning your back because you're typing on the screen. That's not a great experience. So I think those are things you can't measure monetarily, but if you were to ask the patients, certainly we have in our pilot, 9 out of 10 patients like, well, this is great. Now, there's always the one patient who doesn't want to use the technology because we always get consent because we're a two-party consent state in Washington. Some don't want to try it because there's a fear of what is all this about. But as people get used to it, they see that experience improve. So I think we've got to be able to sell a more holistic picture than let's just save a bunch of money.
Excellent. Lots of great stuff in there. Um, let's talk. So I want to explore the idea of getting better over time, which, as you mentioned, is a key element of this, right? We don't expect to save money on day two, but over the number of months and years, we want to continue to deepen usage, improve as the product continues to improve. We take upgrades. Everything should get better and better and better, and everybody happier and happier. How do we do that? You mentioned Dr. Chaudry, informatics folks, your CMIO, Dr. Lynn, who I've interviewed before. Had a great conversation with her. So let's talk about this idea of, we go from pilot to full scale rollout to optimization. Right, Nancy? We want people to get better and usage to get deeper, and that's got to be done thoughtfully. We don't, get to turn it on and then move on to the next thing and forget about it, right? These things don't work that way. So, what are your thoughts around either initial rollout and uptake? And there's different phases here, right?
Yeah.
Optimization, um, and how do you keep track of that and continue to enhance use?
Yeah, I mean, I think early on when you're testing something else out, it's important to get those physician champions on board. So identifying those folks who are willing to work out some of the kinks and, really give good feedback. And those are ultimately the folks that are going to, in essence, train others. So, we, as I mentioned, we had a urologist who was a physician champion, but we have others in primary care who can, go down the hall and, talk about Heidi to other folks. So, getting some, sort of on the ground folks who are, using the technology, getting those early wins. So even though the long-term plan, requires some thought, early wins with the day-to-day workflows, in terms of, wow, I got my notes done at the end of the day. I mean, that's huge for a lot of people, especially in primary care. The other thing that, I think is really important with a lot of initiatives, they tend to be somewhat, either top down or rigid. The beauty of this product and the way we approached it is it has a lot of flexibility. So we're not telling people how to write your notes. We are giving you a tool that you can create templates and you can modify those templates as you see fit. And you can use it to write your notes the way that you see fit. And I think that goes a long way with getting people to adopt something. A lot of burnout is sort of related to this loss of control. But yet, if you give somebody a tool that really, they have control over, that makes a big difference. And it's even beyond the templates. It's, you can use it on your mobile device, you can use it on your desktop, you can use it on your web browser. You can fit it into your workflow in the way that you see fit as a clinician. And that's where I think you get a lot of buy-in by, just giving people control of the technology.
Tom, what are your thoughts on maximizing? Again, we got different phases here. Nancy spoke about an initial phase where you have super users. They probably go into it understanding things are not perfect. We want your feedback. Work out the kinks. She used the term the kinks. Not to imply your product has kinks, but I'm talking in general. So they're using it, not expecting it to be perfect and looking for feedback. Later on, when you roll it out generally, those people are expecting it to be perfect. They're not the guinea pigs. They didn't volunteer to be a guinea pig. And I wonder your thoughts generally around that and just generally around optimization as we move through phases and deepening usage and your thoughts there.
Yeah, I think I would imagine the experience depends on which products you're using. Because obviously, we have many different competitors and different shapes of products. I think they vary from the analogy I always use is sort of like ChatGPT with an integration versus like a co-pilot inside of Microsoft that's like maybe slightly limited, but functions within your record. So they're different versions of the product. If it's one that's more configurable, which Heidi generally is, then it's really important to have a more controlled rollout where you do the initial alpha, you get as many of the specialists as possible to basically do this exploration of what are all the different things that you want to use this for. Because you're right, like that first impression you get as you get to a broader group is harder to control. So you want to make sure that if a cardiologist who's the maybe 100th cardiologist that's coming on board and has been skeptical, when they land on the product, you want to make sure that they're getting all the templates that their colleagues have made and also the content and resources and help that ideally is also from their team. I'd say if the tool is more structured, it's just about filling the fields in the record, then actually I've seen some companies kind of tout going from like 0 to everyone in like 4 week span. And that makes sense because you've got kind of limited customization. So essentially the product's doing a largely similar thing. It's always generating you a SOAP note. Sure, maybe there's a specialty nuance, but it's pretty structured based on what the record lets you do. So it kind of depends, I guess, on the product you have and like the I guess the potential of it is also probably maps to how much time you want to spend with the initial user group, I think.
Okay, very good. Zafar, your thoughts on optimization, and again, this you mentioned we want to be at a far different place 2 to 4 years from now than we are today. How do we get there?
Well, I think it's a continuous learning process, right? So when you first roll out technology like this, any vendor that you use will give you some form of templated result. And the AI will be trained on what your health system does. Because, of course, in every health system, we like to say we're special and we like to do things in a particular way. So, what we've learned in our start to this journey is that for some specialties, the output that was given was what they were looking for. And for other specialties, the output wasn't what they were looking for, because in those particular specialties, the physicians are very verbose. They like to write pages and pages. Psychiatry is a good example of that, right? But when we look at, well, what does standardization look like for the specialty? Everybody wants to say that the patient is a very nice young chap who is pleasant to speak with, but is that really necessary in the note to get to what we need to, which is the clinical care? So it's a continuous improvement. So in specialties that haven't got the output that they thought they were expecting, we're working with the vendor to fine tune and retrain the AI to understand that specialty better, because there is no out of the box product that understands a multitude of specialties, right? You try to put as much as you can in and then improve from there. And that's what we expect to happen. So over a period of time, as our version of the AI is inputting this information, and as we spread this out across our enterprise, it will learn and learn and learn and learn. And over a period of time, it will get to a point where there is mostly agreement. I like to say that children say we use the 80-20 rule. If 80% of people can actually agree, then we're in good shape, because as a physician myself, I don't think all physicians agree on anything. So it's a difficult one to get to 100% stacking hands. So it will just get better. It'll also, certainly in our pediatric specialty, we find the agent is trying to differentiate between the multiple voices in the room, because there isn't just the physician and the patient. Sometimes there's the physician, the patient, the parental caregiver, the grandparent, the uncle, the auntie, who are also saying things, and the agent AI is trying to understand all of those different players. And then you can train it to say, well, actually, it's the room has other participants. So it's still a continuous learning exercise, and it's no different than manufacturing. If you're manufacturing a product, you want to be able to stop the line and say, this isn't correct, we need to correct it now. And then moving forwards, it will be a better output of what you were expecting it to do. The other thing is looking at the different types of accents we have across physicians. The AI is actually doing reasonably well with that, but not 100%. So that's also something the AI is learning. So it's an evolution, right? And I'd ask Dr. Kelly that question, right? Because you have a company who is building these tools, and you probably never started with a tool that was perfect on day one, right? You probably have lots of specialists in your team teaching and training, and as you feed in more client data, it's probably getting better, right? How have you found it?
Yeah. Yeah, I don't know. I'm interested in Nancy's experience. I think I suspect, I don't know what tool the Seattle team used, but there is like a group of tools that is really welded to the medical record, and generally there's a specific reason why some specialties, like psych is a perfect example. So as clinicians, we know psych is incredibly difficult to document, because you're having like an hour conversation with the patient, they're explaining lots of information, you're critically analyzing everything, and at any moment, any sentence they say, so they could say a sentence at the end of a case, I always remember a case where I was seeing someone who was having florid delusions, but actually for the whole hour, the first 55 minutes, I thought they were just telling the truth. And then in the last 5 minutes, I realized, oh, actually, like kind of what they're saying here is defrauding the start of it. I don't think this is true, and this is like changing my whole perception of what's going on. So for AI models, that's really tricky because you've got a really long context of information, and actually, like Heidi in this case would have to recognize that the fact that this portion of the visit is factually incorrect relative to the start of the visit means that I would document this as a clinician saying that we worry about this patient is deluded and blah 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 blah. Like you'd have to write in a specific way. So yeah, I think because we are relatively unbound by the record and we give clinicians flexibility on templates, I think generally we find that it does work fairly well out of the box for a lot of specialties. Um, it can, I think the challenge is usually more like the kinds of documentation that people want to create, whether it's like an MMSE or I don't know, an ADHD assessment according to the DSM criteria, or just a clinical note. Just kind of depends on what they are looking for. But yeah, it's in practice, the way that we learn is pretty much from our users. It's the only way. So we do something like 2 million visits a week, and I think that's why being global is helpful. Like we get everywhere from like Cambridge in the UK to Northern Ireland, where I can barely understand them, to Australians like me, maybe you can barely understand me. So it's I think it's just your product basically gets as good as the surface area of clinical encounters that you see, basically. Um, and also, I think some infrastructure and like product decisions about how it works. Like a good example is a technical thing, but if a product has live transcription, like you're seeing the words come out, generally I know from the technical side that it's probably not going to be that accurate because they're making a trade-off to show that it's working live. But if you do it in batches, the transcription's way more accurate. So that's a product choice, for example. Like we have live transcription, but it's batched every sort of like 10 to 30 seconds, depending on when we hear silence. So yeah, I think it's I don't know. Personally, I actually think the technology is there already. It's mainly just the way that it's built. Like, do you have the ability to do templates, voice settings, other flexibility to get what you need out of it? And and then thinking about sending clinical notes back as like a secondary step, I think is an important differentiation. But yeah, it's just constant effort to keep learning, keep making the product better.
Very good. Nancy, anything you want to weigh in on there?
No, I mean, I think we've found that with accents, it's actually done quite well. I personally use it with interpreters, meaning I'm having a conversation with a Spanish speaking patient and getting the information back. And I have heard this with other languages and it's done very well. So, yeah, our experience has been very positive.
I'd like to explore the issue of we've talked a lot about customization. We've talked about templates, which is a degree of customization. It's sort of standardized customization, right, for different areas. Um, I had a conversation with a CMIO the other day, um, where the discussion revolved around the idea of curbing rogue notes. This will be in our e-newsletter this week, this interview. Rogue notes that he said they caused something like 90% of the problems, these small amount of notes, and clinicians that just sort of had the ability to do some customization that was not beneficial overall, caused some issues with documentation and downstream billing, and he saw causing issues down the road with AI acting on the notes. So I'd like to go through the topic of personalization and customization, which leads to clinician satisfaction, right? The more we can do things the way we particularly want to do them, the happier we'll be, versus this idea of standardization and how AI is going to need to play off of standardized data to be effective down the road. So I'd like if everyone wants to weigh in. Zafar, you want to give me your thoughts on that?
Yeah, so I think I'm not 100% all in on standardization versus customization. I think there has to be a balance that works well for your clinician cohort. I think trying to force absolute standardization wouldn't be a good strategy, certainly in my health system. Trying to encourage some form of consensus does help. So I think, yes, as we have 171 clinical systems feeding our data lake at present. And if we didn't try to standardize some of that data so that it's clean, it's readable, accessible, we wouldn't then be able to act on that multitude of data that's so useful in helping patient outcomes and future service provision.
Mm-hmm.
But I don't think you can force it to the extent that people would like to if you're looking at a technology space, right? I think you have to find a balance between the two. It's not always easy, but it comes through conversation. One thing I've sort of learned in my journey is that most clinicians will be helpful if you include them in the conversation in the first place.
Mhm.
They're not helpful, though, if Zafar goes to them and says, you must do. Everybody loves a good debate in healthcare. So you have to go into the different divisions and you have to talk about, hey, we have this idea, we would like to do, what do you think? And in my organization, I use my team of 15 informatics physicians. This is what we pay them time to do, go and speak to the various groups, see what their plus ones, plus twos, minus one, minus twos are in terms of these crazy ideas sometimes we have, and somehow we get to that neutral point. And I think that normally has been successful in certainly when I've been working in this space, right? So I think that's important to keep in mind. Don't make decisions in isolation. Collaborate as much as you can, communicate as much as you can, and you will see a better output than sometimes we're very good at just coming up. And technology companies haven't played a good part in this, certainly in the AI space, because they've actually been playing the scattergram approach of trying to see everybody they can and sell them on the dream without any centralized way of getting messages out. Because there's a lot of fear. Let's not forget the big elephant in the room here, that AI is creating fear in the workplace. Many people think AI will just take their job. And we know that's not true. You can't replace clinicians with AI. It's another tool on the tool belt. But people fear it. I mean, our nurses fear it. They're like, what is this? Is it really going to do? And it's not, right? I mean, how do you replace a nurse with something that's automating a function? So you've got to take that careful approach to implementing these technologies.
Nancy?
Yeah, I mean, I absolutely agree that there needs to be a balance. If you go too much in either direction, you're going to lose, one thing or another. If it's too standardized, you're going to lose clinicians who want that flexibility. Or maybe you'll lose an important part of the information in the note. I will say there are things that we need to standardize. So you mentioned consent. So same with Massachusetts, we are two-party consent. We have to have a consent. We've done some standard language around how do you obtain that consent. The attestation, we also require an attestation within our notes saying, we have used an AI scribe to help collect the information of the note. That is standard. And the other thing that we did, which is fairly recent, is that we have said to our clinicians that these notes in Heidi AI will be deleted, whether you delete them or not beforehand, in 30 days. And that, again, has to do with only having one medical record as the true source and not having that information out there longer than necessary. We did get some pushback from clinicians who said, well, I want to keep that information because I want to use it for my next Heidi AI note. And So once you help people understand the rationale behind that, they're generally on board. So I think there's things you can standardize and do that thoughtfully. But I am always an advocate for some flexibility in giving control to the people who are using it.
Tom, you're global. Are you seeing, is this a challenge everyone faces everywhere in the world, this standardization versus customization with data?
Yeah, 100%. It's a tricky balance, if maybe if I was a perfect doctor, I would have, structured my notes like just right for the way the system that I used. I think, yeah, I think you can have both. They're not mutually exclusive. So generally we skew towards focusing on the personalization in the initial phase because I think we all experience it with AI tools. What Heidi or ChatGPT or any of these tools create is ultimately going to become my work. So it has to be mine. So it has to feel like something I would have written. I don't want it to be some sort of AI slop or like looks like a medical student or something, or like someone who didn't know was in the room. So I think we generally skew towards that in that phase. But then generally when we integrate with the medical record, that's the point where you then take all of the templates and personalization and we differentiate it. So we have, for example, like this personalization feature that learns individual preference, but it's actually just in the writing of the content. It doesn't actually change the sections, for example. So you may still have the same structured sections that are critical for billing that then get written back into Epic or Cerner or whichever system you're using. But you could still have sections of the note that are just for the urologist or just for their own memory the next time they see them. So that it's totally fine. You can kind of have both. So yeah, generally start in the personalization camp, get everyone excited. Don't lose them on that first impression, like make it a representation of them. And then once you do the integration piece and broader rollout, that's when you bring the structure and like I guess the standardization, because it's almost like you can actually restructure the content as well. We do that sometimes. So, maybe for whatever reason that clinician prefers to write everything in narrative format, which is actually pretty common in psych, for example. So then when we connect to the record, we might do a step where we actually restructure that into ICD-10 based issue list or something. So what they see in the record is maybe not what they keep for their own personal record or what they share with the patient. So I think of it as like the connecting to the record part is where you do the structuring, because that's what's ultimately going to be crystallized. But then the tool side for the clinicians should make them feel like it's theirs, I think.
All right, excellent. Well, Zafar already got in his question to Tom. He snuck that in early, went out of order, but we forgive him. But let's go to Nancy. Nancy, do you have a question for one or both of your co-panelists?
I do. So one thing that we are struggling with, and as mentioned, we are a system of many hospitals. We actually have 5 academic medical centers with lots of trainees. And so there is a debate going on is do you give this tool to our medical students and our interns? Is this something that they should, use, as they're starting their training? Or in one instance, we heard one of the medical education directors say they really need to learn how to write a note first. So, and I have another of the AMCs are saying, nope, they're going to, this is for them moving forward. These are tools that are going to be available throughout their life, and they need to learn how to use it early on and the advantages and the disadvantages to it. So I'd be curious to hear thoughts on that.
Zafar, you want to go first?
So I think the answer is both, right? Because I do agree that medical students need to learn how to write a note, because that's the core basic. But at the same time, I also agree that on day one, when they become a resident, they're going to be exposed to all kinds of these tools. So if they don't get a handle on them, how will they be successful? And we see this from even now, physicians being trained who are never trained on the EMR. And then they have to learn the EMR when they're in training at residency level. So we've decided in our health system that certainly residents will have access to the tool. and we will roll that out. We still haven't answered the medical student question. We're erring on the side of potentially, yes, we do need to train them on using the tool. But yeah, of course, the core basics, I don't think in the training of new physicians, you should forget the core basics. It's kind of like saying that you still need to know how to do a clinical exam, even though you might be using Dr. Google to help you do a lot of things in the future, but you still probably do need to know how to do the core basics on your patient.
Yeah.
Yeah, and just the interesting thing there before I go to you, Tom, is that that comes up, Zafar, in discussions I have around downtime procedures, and how when you have to go to paper, they're young physicians who don't know how to write a note on paper, so that may be a core skill in addition to teaching them the tools that they would need, because at some point they may not have access to the tools, the electronic tools. So it's just something to keep in mind. Tom, your thoughts?
I was gonna say if there's no power, maybe they just go back the old-fashioned way. They just won't document. They have to remember their patients. Um, yeah, I agree with Dr. Chaudry. I think like what we've seen is that so we have this feature called context where clinicians can basically write whatever they like into Heidi, as well as Heidi generating a note. So there's a couple of medical teaching sites that actually use Heidi, and they'll have a template that won't write a note unless they have documented what's in the context. And so basically the template just gives them feedback on what they missed rather than actually creating the note. So there's all sorts of interesting things. Like you could do that. You could also generate an amazing note and then give them feedback on their history taking skills or like areas that they didn't explore. Like that's an interesting area of how you share evidence or like gaps in reasoning or other things. Uh, so yeah, I think I'm kind of mixed. I think you definitely want to learn without it in some ways. Like you want to have maybe some of your consulting time where you're just learning to be a doctor and training, like honing your clinical reasoning, I think. Like in the UK, it's something that the NHS is actually quite actively worried about, like not de-skilling their clinicians inadvertently if the AI is like coming up with the differentials and the issues list and other things. So actually that there it's like clearly a medical device and you have a completely different set of standards of like what Heidi is allowed to create versus not. So yeah, I think somewhere in the middle, like maybe learn without it, and then maybe see the doctors who are working and you're learning from using it in practice could be interesting. Yeah.
All right, listen, we're almost out of time. I think we'll go for a final round of sort of best pieces of advice. Um, I don't know, is there an issue of uh, a cohort of physicians that are not engaging and that's a problem? Dr. Chaudhry, we'll start with you. Is that a problem that needs to be faced, that there's a cohort of users who are not embracing these tools and that something needs to be done about that? Or is that not an issue?
No, I think it's very minimal.
Uh-huh.
And I
Okay.
think it improves with education and communication. So
Uh-huh.
initially, if you just walk up to someone and mention AI, it generates all kinds of reactions. But you have to be able to explain what does it mean to that individual for what they are doing.
Mm-hmm.
And the use case is different for a clinician versus a non-clinician. And that's where we really need to focus efforts on explaining this tool will do this for you, but it won't do that for you. And that we're not really that good at doing that yet. I think that's more work is needed because obviously in technology, many of us are introverts and we're not very good at communicating. So we
Mm.
do need to focus on getting that message clear.
Nancy, any thoughts on that type of dynamic?
Yeah, so we don't see those clinicians as a problem. We are a system that, and I don't think I mentioned this, we're adopting Epic across our system. So we have clinicians who have been on Epic for 10 years. They have perfected their templates, their smart phrases. And so documentation burden was never an issue for them. And they just said, I don't, here's a tool. I don't want to use it. And we said, that's fine. I will say, I think as we learn more about what Heidi can do in terms of capturing a better note, a better patient experience, we want to sort of tip them in that direction. And I would say in any kind of initiative, classic change management 101, you want to get your clinician champions engaged, but also those skeptics, get those skeptics, give them time to sort of express their concerns. And ultimately, they are going to be learning probably from the clinician champions. So right now, we don't see it as a problem, but I think that's going to evolve.
Yeah, I think you're right. I think for sure you're right. Tom, we'll give you the final thought. Everyone's embracing this stuff. It sells itself, and it's a question of rolling it out optimally. You've got the physician champions, the trainers, the at the elbow, and usually what I hear is, you need a myriad of tools and solutions and interventions and trainings and lots of variety, right? Because nobody learns the same, so it's all about variety. I wonder your final thought on, if you agree with that, just the importance of providing that kind of variety so that you're making as many people happy as you can as they try and learn these tools.
Yeah, I think really important. I would say if you're seeing like anything more than, I don't know, like 30-40% of your clinicians not liking it, maybe you're on the wrong tool, to be honest. Like this is pretty universal appeal. Um, Given the correct templates, I think that's the key thing. Like if you give a little bit of flexibility, most people will be able to find the settings that they really like.
Mhm.
And yeah, I think it's like exactly what Nancy and Zafar both said. Like you've got to explore with your own clinicians, your own system. They all are slightly different. What what for that specialty is going to be the correct expression of an AI tool for them. And then I think it'll just go like through a natural adoption curve, even in organizations, no matter how well you do in the change management piece and managing the experience, there'll still be holdouts that will take time. And I think that's up to us to build amazing new things that bring them along. So maybe for a surgeon, like Heidi's evidence product that's starting to roll out will be an amazing thing that they want to use. That maybe they don't find the notes that useful, but they'll start transcribing so they can, pull up research to share with their patients or something. So yeah, there's all sorts of use cases that will come that I think will pull everyone along. Eventually, it will definitely be. I think I will feel unsafe seeing a doctor not using AI in a few years. But I don't think we're quite there yet. But as there's more assistive evidence and other things, I think it'll just be standard practice. And better for the doctors as well. It'll just be a tool we have to use.
Couldn't agree more. Well said. A wonderful panel today. Regarding continuing education, you could use the final slide in this deck. You'll get an email when the on-demand recording of this event is ready for viewing. If you want to work with our team on an event, you could reach out to Nancy Wilcox. You can go to our website to register for upcoming panels. With that, I want to thank our wonderful panel, Dr. Zafar Chaudry, Dr. Nancy Sabati, and Dr. Tom Kelly and Heidi Health for sponsoring, and you for attending. And with that, everybody have a wonderful day. Thank you.
Thank you.
Thanks
Thank
all.
you.
Ciao. Bye bye.